Para concluir estas sesiones plenarias y desarrollar la conferencia Don Pío del Río Ortega, contamos con el profesor Niall Patrick Quinn, profesor of Clinical Neurology del Instituto de Neurología y Honorary Consultant Neurology of National Hospital, Queen Square, London. Please, Professor Niall Quinn, coming to the stage. His lecture in this occasion is about Dr. Samuel Alexander Kinnier Wilson, his disease, and his 1912 brain paper. Thank you.
Presidentes, ladies and gentlemen, it's a great honor to be invited to give this talk in memory of Dr. Rio Ortega. And my talk is going to be about Kinnier Wilson, his disease, and his 1912 brain paper. So I'm not talking about the future like Peter Goadsby, I'm talking historically about the past. So Kinnier Wilson was born in 1878, died in 1937, and he was very close contemporary to Rio Ortega. And I like to think that they might have known each other or met each other. And when I was looking up Rio Ortega, I noticed that he described and discovered oligodendroglaya. And I was originally going to give a talk on MSA, but I've done that already here, and I thought I'd give a talk on Wilson instead. Oops. So Wilson was born in America and came back to England, or to Scotland, when his father died, and he was educated in Edinburgh. And remarkable scholar, he had an arts degree, an MA, at the age of 19 in all those subjects. He qualified as a doctor at the age of 24 with first-class honors. Then he did a BSc in physiology, and then he was a house physician in Edinburgh. And then he took himself to Europe and studied in Paris with Pierre-Marie and Babinski, and in Leipzig with Flechsig. And he was fluent in French and German and wrote particularly in French as well. He was appointed a house physician at the National Hospital, Queen Square, in 1904 when he was 26, and then 4 years later became a registrar. His MD thesis was in Edinburgh University on his disease in 1911, for which he got the gold medal. The thesis only described 3 of his personal cases, and in his large brain paper the following year, he had added an additional case who was still alive at the time. He was later assistant physician at the National Hospital and the full physician. He founded the Journal of Neurology and Psychopathology, which is now the JNNP, in 1920. He gave 5 notable Croonian lectures published in the Lancet on disorders of motility and muscle tone in 1925, and he was Secretary General of the Second International Congress. Unfortunately, he died in 1937 of carcinoma of the colon. And his other great achievement was a wonderful 2-volume textbook on neurology that was published posthumously in 1940. So this is the title page of his paper in Brain. It runs to 215 pages, I think the longest article ever written in Brain. And just to give you an example, one of his cases, the clinical description went on for 15 pages and the pathological description for 33. Well, what I want to do today is to give you a kind of compressed version of what he wrote and to show you the clarity of his thought and the beauty of his writing. So he said, this study is based on 12 recorded cases, in no fewer than 10 of which an autopsy was held. In the large majority, involuntary movements, which form a prominent clinical symptom, are of the nature of tremor rather than chorea. Of these 12 cases, 6 date back more than 20 years. The other 6 are reported in this paper for the first time. And one of the things we're very lucky at Queen Square is to have a very good archive of the bound clinical notes of all the consultants from the mid-19th century round to 1935 or so. And here you see a lot of illustrious names of neurologists who've been there, and I've highlighted in blue some of the names that I will you will come across shortly, and I will come back to some of them later. Now, there were other disputed earlier cases of Wilson's disease, Westphal and Strumpel, and they published cases called pseudosclerosis, and it was doubtful whether they necessarily had the disease that Wilson described or not. But certainly in 1911, Wilson referred to another case that he considered had Wilson's disease in a postscript to his paper in 1912. So this is a slightly busy slide. What I'm going to concentrate on is the patients in blue, who are the patients that Wilson himself looked after and did the post-mortem on whilst he was a registrar at Queen Square. The ones in yellow were previously published cases under different titles whom he considered to have his disease, and so he included in that paper. And there were two in orange there who were hitherto unreported cases. You'll see that in 3 of the families there were multiple siblings involved. The average age for his patients was 16, and the survival was 8 months to 7 years. Of course, we have to remember that this was a universally fatal and untreatable condition at that time and for many years afterwards. Down the right-hand side, you can see the consultants who were looking after the various patients. One of those was Gowers, and he, as well as being a brilliant neurologist, he was a very good artist, and he drew a lot of drawings of his patients, and this is one of his cases in 1886, showing dystonic contractures of his hand and foot. No, I don't think I'll have to come back here and read this because the screen here is, will this work? The screen here is too small. So what he said was the object of this paper is to give a full description of a rare nervous disease of which, as far as I'm aware, no instance has been recorded during the last 20 years. A disease to which the name of progressive lenticular degeneration may be conveniently applied. It occurs always in young people. It is progressive and invariably fatal, its duration ranging from 6 months to 5 years. The symptoms form a complex constituting a pure syndrome of the corpus striatum, and this is the first use of that term in relation to basal ganglia disease. It consists of involuntary movements, nearly always a bilateral tremor of both upper and lower limbs, head and trunk also sometimes involved, usually rhythmical but occasionally irregular and increasing with volitional movement. There is dysphagia and dysarthria, the latter degenerating into complete anarthria. There's sometimes spasmodic laughing and emotionalism. The affection, when it occurs in an uncomplicated form, is an extrapyramidal motor disease. And again, that's the first use of that term in the literature. The pathology of the disease is as striking as the clinical syndrome. The lesion is a bilateral symmetrical softening in the lenticular nucleus involving more particularly the putamen. What must be considered most curious and the most remarkable feature of this familial nervous disease is the constant presence of a profound degree of cirrhosis of the liver. This cirrhosis does not reveal itself by any symptoms during life. Nevertheless, it is always found after death. In that respect, on the earlier slide, there were 2 patients who had jaundice before the recorded onset of the disease. And we have to remember that there were no liver function tests, no liver biopsies, no scans in those days. So making an in vivo diagnosis of liver disease was quite problematic. In this paper, we described 4 cases which have been personally observed and diagnosed, in 3 of which has had a post-mortem. So this is Wilson's case 1, Sylvia Tyler, and the physician was Sir David Ferrier. She was a retired coal agent, and the diagnosis in her notes was cortical degeneration and clonic tremor. He said, at that time I was not aware of previous similar cases, but it was certain that this case was one of a nervous disease which didn't correspond to any familiar type. Sir David Ferrier considered that while it bore certain resemblances both to disseminated sclerosis and to paralysis agitans, it was quite distinct from either. This case was followed up without delay, and a year later the autopsy revealed what was fully expected: cirrhosis of the liver and lenticular degeneration. In the brain, the eye was at once caught by remarkable bilateral cavitation of the lenticular nucleus. A year later, case 2 came into hospital under Dr. Ormerod, and whenever I saw her, I recognized that her condition was identical to that of case 1, who had been in hospital a year previously. It was this case that supplied the clue to the mystery, for the patient died not long afterwards, and at the post-mortem made by Dr. Stoddart and myself, an unsuspected cirrhosis of the liver was discovered. And there you see the unfortunate woman with a very prominent dystonic smile. Case 3 is wonderfully described. He was the brother of case 2, and he says, from beginning to end, he was under my observation. He was sent to be under the care of Dr. Raymond at a sanatorium in Chèvres, near Lausanne, in Switzerland. As the patient had not been seen by any neurologist since the onset of the symptoms in autumn 1907, it appeared to me desirable to investigate his condition for myself. Accordingly, an early opportunity was taken of paying a visit to the sanatorium where he was living, and the greater part of June the 4th, 1910 was spent in examining him. So doing a domiciliary in 1910 or in 1907 on a patient in Switzerland when you were working in London was quite something to do. As I walked around the corner of the building and came upon the patient sitting in a lounge chair in the sun, the impression I received was one not easily to be forgotten. He was leaning back with a broad smile on his face, his mouth wide open and saliva dribbling from it onto his chest. His arms and hands were in a state of contracture and drawn up, moving to and fro ceaselessly with a quick rhythmical tremor, his toes tapping the ground with a similar rhythm. His whole attitude was one of vacant complexity. And there you see him sitting in the Alps, or the Jura, in the sun, with his dystonic mouth wide open and these contractures. His mental state was one of great facility. He was as docile as a child. He did whatever he was told to do, often with a brief, involuntary, explosive laugh. Aware of this mental condition, some of his fellow patients would say, "Open your mouth, Mr. P." And this he would at once do to the accompaniment of bursts of laughter. He laughed constantly while he was being examined. If his mouth were wiped, he passed at once from his smile to his laugh. When his reflexes were tested, he burst into a loud rire spasmodique. On a subsequent visit in 1910, Wilson did the autopsy, 27 hours after death. He wrote, as the body had been kept in the open air, the sanatorium being at a considerable altitude and the nights very cold, it was in an excellent state of preservation. In his case, also, similar pathological findings were obtained at the autopsy. This is case 4 of Wilson under the care of Dr. Tooth for a short time, who at the time of writing was still living. And this is the patient's complaint: a young woman with shaking of the right arm and leg, inability to speak, difficulty in swallowing and chewing, of 12 months duration. And there, just in that entry in the notes, if you're smart enough, you immediately suspect the possibility of Wilson's disease. This was her front page of the notes. The consultant was Dr. Tooth. Interestingly, the house physician was a certain Dr. Greenfield, the later pathologist, and she was a music seller, aged 20. And this is the first time that I think this diagnosis was actually written in a living patient's notes, saying progressive lenticular degeneration. And that is the poor lady again with a dystonic smile. So he wrote later, 2 clinical types may be distinguished, one acute or subacute and the other chronic. It's a motor disease par excellence, and its most striking characteristics are disturbances of motor function. In one of two of the cases which what caught the eye of the observer was not so much tremor as tonic or clonic spasms. Progressive ventricular degeneration is a nosological term which I propose to denote the disease. In view of the fact that the clinical symptoms are exclusively nervous, it's well to adopt a neurologically descriptive term. The essential fact of hepatic cirrhosis may be mentioned in a subtitle. It seems that this is a descriptive term which is brief, distinctive, based on pathological data, and at the same time non-committal, inasmuch as it entails no acceptance of a particular hypothesis as to the actual nature of the disease. This is a very, if we could play the video, please. This is a very short clip of, made by Wilson in about 1925. He made films of a number of patients in Queen Square. He was very friendly with Charlie Chaplin, and I think that gave his enthusiasm about cinematography. And again, this ferocious tremor and the dystonic smile. We can stop the video there. And I want to move forward quite a number of years to my last slide, which is from, we had a Wilson disease centenary meeting at the Royal College of Physicians in London in 2012. And on your left there is Kinnier Wilson's son, who's now 96, and he's a professor of Assyriology in Cambridge University. And on the right is Dr. John Walsh, metabolic physician at Cambridge, who's still alive, aged 97. And he, in fact, was the son of Sir Francis Walsh, who was a consultant neurologist at Queen Square on that list that I showed you. And the first patient that John Walsh introduced penicillamine and also triantine for the treatment of Wilson's disease. In fact, he was the first person in the world to swallow penicillamine, which he did himself before giving it to any patients. And he introduced the treatment in 1956. And the first patient he treated was a patient at Queen Square of his father, Francis Walsh. So another familial aspect of Wilson's disease. And when I last heard, this lady was still alive and in perfect health. And I think he made one of the most outstanding contributions to medicine, taking a universally fatal disease in young people and making it curable. Thank you.